Hi everyone, welcome to today's LACNETS webinar, Nutrition and Neuroendocrine Cancer with NET Dietitian Tara Whyand. I'm Lindsay, the Director of Communications for LACNETS, and this is...
I'm Lisa, I'm the Program Director for LACNETS.
Before we get started today, I'd like to take a second to thank Rich at TVP Live for making today's webinar and high quality production possible. You're the best, Rich. We will be having a live Q&A following Tara's presentation. To submit your non-case specific questions for today's speaker, go to www.slido.com and enter event code LACNETS. Also, here are a few tech tips for today's webinar. For audio, be sure the volume is turned all the way up on your computer. Also, double check that the volume is unmuted on the webinar broadcast screen. For your video, you can enlarge the webinar broadcast screen by clicking the Expand Screen button in the bottom right corner. And the full webinar video, as a reminder, will be posted on the LACNETS YouTube channel within the next few days. Our LACNETS YouTube channel has 100 plus net videos, so be sure to check it out. Also, as a reminder, these webinars are done for educational purposes only and do not substitute for medical advice. Please talk to your medical team if you have any questions or concerns about your individual care or treatment. We all have our own opinions, and these are our own opinions. They do not necessarily represent the opinions of LACNETS. And now I'll pass it off to Lisa.
Thanks, Lindsay. LACNETS, as you know, is a program by GeneratePossibility.org, a registered nonprofit, and LACNETS stands for the Los Angeles Carcinoid Neuroendocrine Tumor Society. Our mission is to provide education, advocacy, and support for all people impacted by this rare disease that used to be known as carcinoid, an old term meaning cancer-like. The more accurate term is neuroendocrine tumor, or NET for short. It's also called neuroendocrine neoplasm, and you'll often hear us say neuroendocrine cancer since we understand NET is a type of cancer and not cancer-like or benign as previously thought. While you often see Lindsay and I leading the meetings and programs, we are actually led by a team which includes our interim administrator and board member Kavya Velagapudi and board member Donna Gavin, who is also the sister of LACNETS founder and executive director emeritus Giovanna Joyce Mbasi. Our newest board member is Mary Dunleavy, who is living and thriving with NET. I'm excited to introduce today's speaker, Tara Whyand. NET Dietitian Tara Whyand is joining us from across the pond, all the way from the United Kingdom, to discuss a very popular topic in our community, nutrition and neuroendocrine cancer. She's well-versed in NET nutrition, as she's been working directly with NET patients for many years in the hospital, clinic, and also privately. Tara is a distinguished guest speaker at national and international NET conferences. She's been published in NET journals and research articles. And here's a fun fact. Some of you may know that Lindsay and I both love dogs, and particularly rescue dogs. Lindsay has 2 German Shepherd rescues, and I just adopted a rescue puppy this weekend. We learned that Tara shares a love for rescue dogs and has 2 rescue greyhounds of her own. So we're delighted and grateful that we're connected in so many ways, and even more so in this virtual world. Thank you, Tara, for joining us today. Now I'm thrilled to welcome today's speaker, Tara Whyand.
Thanks, Lisa. My name's Tara Whyand, and I'm a neuroendocrine cancer specialist dietitian based in England. So I've been specialising in neuroendocrine cancer for about 8 or 9 years. So today I've got a presentation covering some key issues. So first of all, as a patient, obviously you'll know that neuroendocrine cancer is a complex kind of cancer, and and the treatment and the cancer can lead to a variety of complex nutritional problems. So these problems can be digestive problems. So often people have, lots of diarrhea due to their hormones that their tumours are producing, or the peptides that are released. But sometimes the cancer itself can also cause an obstruction of the bowel, and the thickening and the scar tissue called desmoplasia can actually lead to an obstruction as well. So that can really show up as a feeling of constipation, but it might not necessarily be constipation, it may be an actual blockage. There are problems when people have surgery. Sometimes these are short-term problems, but if you're removing part of the bowel or the pancreas, then you remove some of your ability to digest food and absorb food. So sometimes these are short-term issues, and sometimes these are long-term issues. Medications can cause malabsorption. So, for example, proton pump inhibitors, so antacid drugs, they can cause problems with B12 levels and the absorption of B12, or there's things like somatostatin analogues, which can cause fat-soluble vitamin malabsorption. There are issues with other types of therapy. So, for example, chemotherapy, you can have lots of diarrhea, and sometimes people actually get the opposite and have constipation as well. So first up, I'm going to cover the topic of loose stools. So no neuroendocrine cancer presentation could be without the topic of loose stools somewhere. So one of the main causes in functioning neuroendocrine cancer is hormone release or peptide release. So where the tumour is uncontrolled and it's still producing these hormones and peptides, which cause diarrhea. Another cause is pancreatic exocrine insufficiency. So this is where the pancreas is insufficient in producing its own enzymes. So sometimes it can't produce any, sometimes it just produces less due to the treatment or pancreatic surgery or other health conditions. Something called pellagra, which is niacin deficiency, so vitamin B3 deficiency. This can cause diarrhea. It's more common in people with carcinoid syndrome or with tumours which secrete serotonin, and I'll cover this shortly. A different form of diarrhea, so still a loose stool, but it's more of an acidic burning diarrhea, and this is called bile acid malabsorption or bile acid deficiency. Something quite different to that is small intestinal bacterial overgrowth. So this is where there's an overgrowth of bacteria in the small intestine for multiple reasons, and it's often linked to diarrhea and gas from hydrogen producing bacteria. You can get overflow diarrhea, so where you initially have constipation, you haven't opened your bowels for a few days, and then when they do open, it's called overflow. So you suddenly get the diarrhea, which has been kind of building up in the bowel. There's things like hyperthyroidism, so hyperthyroidism, where there's too much thyroid hormone production. And sometimes, this can be found in neuroendocrine cancer or outside neuroendocrine cancer, but it can be something that goes alongside. There's things like IBD, so inflammatory bowel disease. So often people with neuroendocrine cancer have other health conditions as well. And we do see, Crohn's disease and ulcerative colitis as well as IBS, so irritable bowel syndrome, and celiac disease. Sometimes we have a few patients with coexisting intestinal neuroendocrine cancer and celiac disease, which throws extra nutritional problems into the mix. And then there's things like common food poisoning and infections. And so when people have loose stools, actually sometimes they have a mix of several forms of loose stools. Sometimes it's a watery diarrhea and sometimes it's steatorrhea. And because it's such a complex cancer and there's so many different treatments, actually some people suffer 2-3 types of diarrhea at some point. So the first point in terms of pancreatic exocrine insufficiency. So this is where food, so carbohydrate, protein and fat, are insufficiently broken down. And we see this in most pancreatic cancers, including neuroendocrine pancreatic cancer. And this is because the tumour might have kind of grown into an area which is producing the enzymes or blocking off the production and release into the top of the small intestine. Sometimes that can be made worse by having pancreatic surgery, so the region has actually been chopped out. And the use of somatostatin analogues is very key to neuroendocrine cancer treatment, but it actually reduces the capacity of your own pancreas to make your own enzymes to break down your food. There's things like diabetes now, which we're looking into research in terms of just having diabetes and the inflammation of the pancreas, that may actually cause insufficiency as well. And there's things like cystic fibrosis, which cause the same kind of issues. So why is it important? It's important because you have this awful steatorrhea, so this more fatty, smelly, frothy diarrhea. And this actually, where you're malabsorbing food, you're not getting the nutrients from your food, and it causes fat-soluble vitamin deficiency. So what we do is prescribe pancreatic enzyme replacement therapy, what we call PERT. And this contains lipase, which breaks down fat, protease, which breaks down protein, and amylase, which breaks down carbohydrate. We can test people using a fecal elastase test as well. However, if someone's on somatostatin analogues, one of the studies actually that came out of Wales showed that the reliability of that test isn't actually very good. And we know that a lot of people get insufficiency once they start somatostatin analogues. So whether it's worthwhile doing a test, it's probably best discussed with your team. So there are different enzyme types. The only medically tested enzymes are from pigs, so what we call porcine origin, and they're gastro-resistant, which means that the stomach isn't going to affect them, it isn't going to digest them. It means that this capsule can go down through the stomach and then come out the other end into the duodenum, and then the capsule will start to melt away and release the enzymes. We don't want it to be digested by the stomach. So there are vegan and vegetarian supplements and things sold on Amazon, and they're alternative, really. We don't support the use because they are not gastro-resistant and they're not tested, so they're not prescribable, and they may be cheaper. I'm aware of the costs involved, but because they're not medically tested, we can't promote their use. And often they're low doses of the enzymes, even if the enzymes work. So if you can possibly get the medically prescribed ones, that's what we would recommend. So where we're talking about the PERT dosing, we really need this to be under the care of your dietitian. So the most popular brand is Creon, and we start with a dose of 24,000 or 25,000 units of lipase per snack, and then 2 per main meal. We then increase the dose by 1 capsule and monitor the symptoms. So it depends what country you're in. We use a 24,000 dose or 25. Basically, you have to monitor your symptoms, and once your symptoms resolve, you know you're kind of at the right dose. There is a maximum dose limit. You can damage your bowel if you have too much every day, and the maximum limit is 10,000 units of lipase per kilogram of body weight per day. So, for example, a 70 kilo person would need to consume 700,000 units of lipase per day and no more. So if you look at the website for Creon, you may have noticed that you calculate your dose based on fat. So that's quite a good way of doing it, because the more fat you eat, the more enzymes you know that you'll need to break down. But don't forget, it's not just about breaking down fat. If you have severe pancreatic exocrine insufficiency, you also need to break down the carbohydrate and the protein as well. Because if you're not breaking down those things, then you will get malabsorption symptoms, and you will lose weight, and you can also become deficient in those fat-soluble vitamins. So the timing of taking these enzymes is really important. So these enzymes are never going to be as good as your own enzymes, and therefore you need to help them work as best as possible. So take the first half of the dose with your first mouthful and the other halfway through the meal. Don't take them after, because it's too late. The enzymes need to be in your duodenum, mixed up with your food, just in time for your food to get into the duodenum and start munching away on it. If you're then having a dessert, then you need to have more, especially if you're having a big dessert or ice cream, something with lots of fat, which often desserts have. So sometimes people don't do very well when they start with the enzymes, and they're still getting, weight loss and steatorrhea. So we have to go through a checklist at that point, and the best person to do that is the dietitian. So we check that you're taking them correctly. So as I just went through, are you taking an adequate dose? So I know over here, sometimes people are still prescribed 10,000 units, which is a child's dose, and they're just taking that at any time, or maybe half an hour after the meal, and surprise, surprise, it's not working. It's not going to work. It's not enough. You have to take enough enzymes to break down the food. One of the things that we do here is use a proton pump inhibitor, so a form of antacid drug, and this reduces the gastric acid in your stomach, because if you have got too much acid, then it can affect the enzymes working, and we need to lower that acid for the stomach to release the enzymes into your duodenum, and then they can happily start munching away on your food. Sometimes people with certain neuroendocrine cancers have lots and lots of acid, and they can be at risk of duodenal ulcers. So in those people especially, we really need to keep those people on the antacid drugs. And then obviously we need to look at the timing of taking the enzymes, so making sure that it's really with the first mouthful and then halfway through the meal, and as I said before, not after, because that would be a waste of time. So different topic, very different topic, as I mentioned earlier, pellagra. So this is the visual symptoms that you see as a result of niacin deficiency. There's been 2 studies looking at the incidence of vitamin B deficiency in patients with neuroendocrine cancer and serotonin producing tumours. So one study showed that up to 28% of patients with a serotonin producing tumours off somatostatin analogues, so not on them at all, actually had a very low niacin number. So that's a blood test. And this was a US study, I think. And some of them had carcinoid syndrome and some didn't, but they had the capability of their tumour to produce serotonin. A different study, which was a Dutch study, found with a urine test, so not the blood test, that 45% of their patients newly diagnosed with a serotonin producing tumour had a low level of niacin. I tend to put patients on a preventative dose. So I say about 100 milligrams of niacin, so it's a form of nicotinamide, per day, is a good enough amount to prevent deficiency in niacin. Actually, if someone's showing symptoms, so they're showing pellagra, they do need the doctor to diagnose this, but the treatment from the World Health Organization is 300 milligrams per day for a month. And then they want someone to be retested just to make sure that their niacin levels are high enough. So often I see this in Facebook groups and people showing, different skin conditions and showing pictures of, lumps and bumps that they've got. And skin problems are what we're looking for if we're thinking that pellagra and niacin deficiency is an issue. So the signs of pellagra involve skin lumps and bumps, problems with the mouth, so inside the mouth, the lining of the mouth, and the lining of the intestinal tract, which then develops into diarrhea. And we have problems with the central nervous system, especially when we're going into moderate and severe deficiency of niacin. And the four things that we often talk about are dermatitis, diarrhea, dementia, and the fourth D is actually death. So when things get so severe, you can actually die of it. I've not known anyone with neuroendocrine cancer to die of that. However, it should always be at the back of our mind that when we see these kind of things, actually, is it pellagra? And I don't think we should, forget to talk about this. So on to the next subject of bile acid malabsorption. So there are three types of this. Type 1 is where there's a problem in the part of the small intestine. So the very last bit is called the ileum. And this is where reabsorption takes place of these bile acids. So the causes include any kind of inflammation, so removal of the ileum due to Crohn's disease or cancer. So cancer can be present or it's just been removed. So type 2 is where there's no definitive cause and where it's been investigated and actually they just can't find anything. And that's known as primary bile acid malabsorption. And then there's type 3, which can result from other diseases or conditions within the abdomen, such as the gallbladder removal. So sometimes you get this steatorrhea and kind of acidic steatorrhea. Because the gallbladder has been removed. Or there's things like celiac disease and chronic pancreatitis. Radiotherapy can cause these issues. And then finally, small intestinal bacterial overgrowth, which I'll go on to talk about. So the treatment is actually with bile acid sequestrants. So these are powders or tablets, and these bind these acids so they don't cause you a problem. As dietitians, we also use a low-fat diet, and that can be alongside these medical treatments as well. And we monitor the fat-soluble vitamin levels in these patients as well, because when you're on a bile acid sequestrant, it can also bind to these vitamins within the body as well. So onto the subject of small intestinal bacterial overgrowth. So we have two different types of bacterial overgrowth. So there are methane exhalers. So these are overgrowth of bacteria which produce methane. And then and these people often present with constipation or trapped wind and constipation. And then there are the most common kind, which are the hydrogen exhalers, and these people present with diarrhea and often wind and diarrhea. And we say they're exhalers because the test is actually exhaling into a bag, and this measures the amount of gas in your breath that the bacteria have actually produced. So there are no proven dietary interventions yet, although I know in the States there's lots of research going on. But there's not one type of kind of cure. The only thing that we know helps is a antibiotic called rifaximin, and that's just for the hydrogen exhaling diarrhea predominant overgrowth. We often use things like probiotics or the low FODMAP diet and meal gaps to actually minimise the symptoms, and this can be done during treatment with rifaximin, and it can be done, just to kind of stave off the reoccurrence, which often happens. And then there's fecal transplants. So this is where you actually transplant poo from one healthy person with a healthy gut into someone with a gut that needs a bit of help. So although this sounds awful, you take the poo of a healthy person, freeze dry it in a medical procedure. It's freeze dried, put into a capsule, and then via a camera and a medical device is inserted into the small bowel. So this can work with things like C. difficile infection and other gut disorders. However, we don't know whether it works long term. So you may displace the bacteria that are causing an issue, but whether that will return or not, we are yet to know. There can be an issue with vitamins and minerals, so like any kind of malabsorption, where you're not absorbing food, you're not absorbing the vitamins and minerals. So there can be issues in deficiencies as well. So often syndromic diarrhea, so things like carcinoid syndrome are often blamed for loose stools. And as you've heard already, there's lots of different types of diarrhea. So I didn't want to focus on this or talk about this first because actually when you have a tumour controlled and you're on a treatment which is working, you shouldn't actually get that much diarrhea from the actual syndrome, the hormones and the peptides. So obviously there's carcinoid syndrome, but we can't forget about the people with rarer tumours, so things like lipomas, which produce this awful diarrhea 20-25 times a day, just very watery diarrhea, and those people really need help with replacing fluids and electrolytes as well. In terms of dietary triggers, often people want to give for me to give a list of dietary triggers for when they have carcinoid syndrome. And actually there is no one list that everyone will react to. Actually, people don't often react to any of the triggers. So we don't give people a list of things to exclude because often they're okay to have all of those things. So it's not a very well studied area. I don't think there's really any research, any proper research that's been done in terms of carcinoid dietary triggers. And it's good to remember that carcinoid syndrome will continue, this diarrhea will continue with or without food. So actually starving yourself isn't really going to help that much. We do know that high vasoactive amine foods or drinks can trigger symptoms in a small proportion of people with carcinoid syndrome. These kind of foods include foods and drinks in this table. So all cured meat, especially from pork products. So things that are cured include ham, salami, pepperoni, bacon, all those kind of things, but also canned fish. Milk and eggs can be a problem if they're not fresh. So if you don't have fresh milk, especially, it's an aging process which releases these vasoactive amines. Most cheeses are not fresh, they are matured. So the more mature, the more old something is, these protein items, they release these vasoactive amines. Unfortunately, some of the fruits can cause people a problem. These include the kind of citrusy fruits, the sharper acidic fruits, and things like tomatoes can cause an issue, or fermented pickled cabbage and those kind of things. Lots of nuts are on the list. And then fermented soya products, more so in the kind of Japanese type diets. And unfortunately, there's lots of drinks which can be a problem, including green tea, which people often try to drink because it's healthy. But things like champagne or wine that's actually made in an oak barrel can be an issue. If it's made in a metal barrel, it's actually not an issue for most people. So when we're looking at food triggers, it's best to go through your diet with the dietitian, and we use food and symptom diaries. So we're only going to look at excluding known triggers if they definitely cause an issue. So within an hour of having a food or drink, are you getting flushing? Are you getting diarrhea? If you're not, then it probably isn't the food that's causing the issue, and we have to have a look at what are the other things that can cause those symptoms. Remember that alcohol can include vasoactive amines, and if you're having lots and lots of diarrhea and your carcinoid syndrome is not controlled on treatment, then we will be looking at replacing the fluid and the electrolytes just to keep you hydrated. So I didn't want to forget the subject of celiac disease. So 1% of the US population have celiac disease. And as I said before, it's also possible to also have celiac disease and a neuroendocrine cancer. Sometimes people go gluten-free because they believe that gluten-free is a healthier diet. And sometimes these people have celiac disease, although it's not good to go gluten-free before your celiac test. You need to have gluten in your diet for that. But where people are just trying different diets out, actually, sometimes it's wheat intolerance and nothing to do with the gluten. Gluten is not often the culprit. So outside of celiac disease, we don't recommend a gluten-free diet, really. Although if IBS is diagnosed too, a low FODMAP diet, which includes a very, very low level of gluten, can be trialled, but this must be through a dietitian. So on the opposite end of the spectrum, not loose stools, but the constipation issue. And actually we did a survey a few years ago looking at the side effects that people were getting when they started somatostatin analogues, and constipation or really difficulty actually expelling all the stools that someone needed to expel. So difficulty in feeling that they're having a good emptying of their bowels was the biggest issue, not loose stools. So we can't forget about these people that really struggle with this and the pain and trapped wind that constipation can cause. So what we would do is look at the amount of fibre. Sometimes people have a really plant-based diet and have so much fibre, and sometimes they don't have enough fluid to go with that fibre. If you're having a high fibre diet, you need more fluid to be able to soften the stools and keep everything moving through the bowels. If the bowels are very dry, they're not going to move. So you have to, it's kind of lubricating the bowels, making sure you have enough fluid in there as well. Exercise, so like the Romans used to do, always exercise, go for a walk after a meal, get your bowels moving. If you're sat down all the time, it's really difficult to sometimes to have a bowel movement. As I mentioned before, small intestinal bacterial overgrowth of the methane producing variety can cause constipation and wind. We would try manipulating all the fluids and fibres and trying to get people moving more. But we can also trial supplements, so different fibre supplements, linseeds, flax seeds, increase someone's fluid. And then also we often talk about, what kind of exercise is possible for you right now. I know we're all kind of restricted at the moment, but there are things you can do in your home. You don't have to go outside for a walk. So gas or wind can be a problem. So by this I mean burping, so burping wind, or the other direction, so flatulence, or even worse, when wind is trapped somewhere in the middle. So wind and air can be swallowed, or it can be produced by stomach acid or microorganisms. So even things like yeast or bacteria can produce all this gas. And this really needs a dietitian assessment to see if food is the culprit. Sometimes it's nothing to do with food. So we look at things like wheat or fructose intolerance, lactose. Is it something to do with the kind of enzymes that you're on? Are you eating too quickly and swallowing air? Are you having chewing gum? Or are you having lots of broccoli and sprouts and all these brassica kind of vegetables, garlic and onion, which can cause an issue? Some of the things that can help are prescribed, but the things that we can promote and you can have a go with, things like peppermint tea or charcoal tablets. And people have their own kind of techniques, and sometimes it is food, but sometimes it isn't. So I just wanted to mention briefly bowel surgery. So often people have like a right hemicolectomy, most commonly when they have an ileal tumour. And this is where the small bowel at the very end is taken away along with the very first part of the large bowel. And for example, in this kind of surgery, it can take up to 2 years for things to heal and really settle. So initially when you have the operation, not everyone, but you get this awful diarrhea, and the bowel is very intolerant to food, and you can get this diarrhea that goes on for months. And yes, it can last up to 2 years. For most people it doesn't, but you have to give it time to settle. And originally when you're in hospital, you may be told to have a low fibre diet, or you may see a dietitian or be given a diet sheet saying, you must have a low fibre diet, but that's not actually forever. It's just until your bowels settle down. So for most people, after a couple of months, actually, you're okay to have a normal amount of fibre, so healthy eating again within a couple of months. Unless you have a bowel obstruction or you're at risk of a bowel obstruction, or you have things like diverticulitis, is where you have pockets within the bowel which get inflamed because they have little bits of seeds or skins and pith from oranges and things stuck in there, and then they get inflamed. But having a colonoscopy can have a look for these issues, and if you've had a colonoscopy, you'd know whether you had that or not. So I just wanted to mention ketogenic diets. Ketogenic diets are often a hot topic. And basically, it's kind of originated by the work that went on in epilepsy. So originally, ketogenic diets were used for children to control their epileptic fits. And really, it's been translated into cancer care because we know that some of the cancer drugs that we use interrupt the metabolism of cancer cells. And so people have started to think, how can we interrupt metabolism of these cells? Can we, go for a lower carbohydrate higher fat, higher protein diet and starve these cells of carbohydrate. Actually, there's still no evidence or research that's been done on keto diets and neuroendocrine cancer. All the different types of neuroendocrine cancer, there's still nothing that's been done. I don't know whether there's anything planned or not, but there's plenty of studies in other cancers. So I just wanted to briefly explain those other cancers. So brain tumours, so a form of brain tumour, glioblastoma, breast cancer, ovarian cancer, endometrial cancer. They've looked at the effect of a ketogenic diet on weight and cholesterol and quality of life. Those studies were done for 12 weeks, so only 3 months, and we don't know the long-term risks of taking a ketogenic diet. Those studies showed that within 12 weeks there were minimal changes to weight and cholesterol level, but are we really looking at that in terms of when people want to take ketogenic diets for cancer control? Because this is why most people would like to actually have a ketogenic diet. You know, is there something that they can do themselves with their diet to help control the cancer? So it wouldn't really relate to neuroendocrine cancer if we're just talking about weight and cholesterol so much. But they also looked at quality of life, and actually, although these diets are very restricted, a lot of people said actually they feel better. But when you throw into the mix things like chemotherapies or other drugs that people are on, radiotherapy, actually the compliance in these patients dropped because it's so hard to follow a ketogenic diet and go through these quite tough cancer therapies. Some of the studies were very small sample sizes, so small groups of patients, including one study with lung cancer and pancreatic adenocarcinoma patients. So collectively, when we look at all the evidence, there's nothing in neuroendocrine cancer. And the current studies, even in other cancers, actually lack evidence to really promote it. There are a few ongoing studies I know over here in the glioblastomas, the brain tumours, but I don't think there's enough evidence for us to be using it in neuroendocrine cancer. And plus, these studies really need to look at what we're interested in. Does it increase survival? And does it they need to report the progression-free survival, basically, so the period where possibly this ketogenic diet might be controlling the tumour growth. Thanks for listening. If you would like any more information, you can search my name on YouTube because I've designed lots of very small kind of snippets of information and hope you enjoy. Thank you.
Tara, thank you again for that really amazing presentation. We've learned so much from you. And as you know, this is one of the most popular topics in our community. Just as a reminder for the Q&A, if anyone has any questions, go ahead and submit them on Slido. And we will answer them as we go. And we have about 45 minutes for a live Q&A. And as a reminder, again, I know Lindsay said this at the beginning, this is not a substitute for medical advice. Tara is not here giving medical advice, and we encourage you to consult your physician if you have any questions and concerns. So this is just for educational purposes only, and we'll take non-case specific questions. So Tara, thank you for agreeing to answer the questions that come up. I know there are so many, and it's good to have you here.
Thank you.
So one of the first questions, you know, a lot of questions come up about what to avoid, and I know you touched on this already. So a specific question is, I've read that people with NETs should avoid smoked, fermented, or other aged foods. Is this true, regardless of where the primary tumor was?
Okay, so it's not really to do with where the primary tumour is. So some people with carcinoid syndrome may react to vasoactive amines. So these are things basically produced from aging protein, and they're released as part of the aging process. And they're similar type of things to what people with migraines try to avoid, because they change the blood pressure within the small capillaries and cause a migraine. So if you have carcinoid syndrome, you may or may not react to these vasoactive amines. There's really no research, no published research at the moment to look at these exact foods. However, we know that people do report some kind of trigger, especially flushing, sometimes diarrhea, sometimes wheezing, but it's mainly flushing. So it's only those people with neuroendocrine cancer with carcinoid syndrome. And sometimes people have carcinoid syndrome and then they start treatment and then it's controlled completely and they don't need to avoid these foods. There is no entire list of foods to eliminate. That's the first thing that I come across a lot, is that people see the list and they eliminate everything. And really all you need to do is a food and symptom diary, and hopefully if you have access to a dietitian, then you submit your food and symptom diary to the dietitian and they can look at whether really that food has caused a problem or not. So that it's best to do that.
Yeah. Yeah, we're all zebras, right? There's no one list. You know, a follow-up question for that, I know it's not on there, but oftentimes people ask about these triggers, this list and these triggers. Would they worsen if you start somatostatin analogs, or do they get better if you start somatostatin analogs?
I mean, theoretically, it should get better if the somatostatin analog is controlling the tumour. Most people won't have triggers of any kind. I know 5-10 years ago we talked about large meals causing a problem, fatty meals, alcohol. They're not really tumour triggers or carcinoid syndrome triggers. It's mainly these vasoactive amines, I suspect, that are the main problem. But certainly if you're on treatment, you should have less triggers.
Yeah, thank you for that. And speaking of other things that people are trying to avoid, sugar is a hot topic, as you know. And one person specifically is saying, after 15 years on somatostatin analogs, I find I crave sugar. How do I satisfy those cravings without jeopardizing my health?
Yeah, I mean, cravings are not a listed side effect of somatostatin analogs. I haven't heard cravings associated before, and it may be nothing to do with the actual treatment. In terms of advice to that person, I mean, sugar cravings can happen if you're just trying to avoid sugar. I think the first thing you need to look at is whether you need to really avoid sugar, because most people don't. It's very, very rare to have to avoid sugar. You can have a small amount in your diet. And if you want something sweet, of course, the healthiest things are fruit and things like that. So just try and have a few fruits every day, and try to go for the healthier options.
Thank you for that. And on a related note, there's someone here who said that in an effort to reduce my A1C, I now use stevia as a sweetener for my tea. I notice sorbitol or erythritol as a first ingredient. Is there one better than another? So I guess this person, also isn't just trying to avoid sugar, but they really want to control their A1C.
Yeah, I guess, I mean, I don't have the information whether they have pre-diabetes or diabetes or anything like that, or what the level is. But if you are using sweeteners, then I think you have different rules in the US, but certainly we don't restrict any of them here. So there's no one better than the other.
Okay. Thank you for that. And, there's some general questions that come up about how to keep a balance especially when they're going through therapy. So this person is on a very restricted diet while on targeted therapy. So they want to know what to include in their diet every day for normal living.
That's a really difficult question. So as you know, it's really about individual diet. So there is no one diet or one food or set of foods for me to recommend. It's about having a long sit down with the dietitian and having something tailored to you. I'm not sure what drug it is, but it's based on what your weight is, what kind of neuroendocrine cancer you have, maybe what stage it's at, how active it is, your lifestyle, how much exercise you have. So it's just, you just need to have a sit down with a dietitian.
Yes, yes. This is a really common question that comes up about, understanding that some foods trigger syndromes, but also wondering if they affect the growth of the cancer.
That's actually something that we don't know. Just going back to the first question about carcinoid trigger foods, we don't think that those foods, if they cause a flush or anything, will cause a problem. But we haven't got any research to say either way. So until that research is done, I can't give you a definite answer. But my impression would be that no, it wouldn't cause harm.
Okay. And I'm glad you covered keto diet because that is so popular of a topic, and I'm sure you get that a lot. Another common question comes up around whether or not to avoid meat and whether a vegetarian or even a vegan diet is better for preventing or controlling cancer.
We don't promote veganism or vegetarian diets. The main reason is that once you're diagnosed with a cancer, you actually have a very high protein requirement. And if you're already on a vegan diet or vegetarian diet, that's absolutely fine. It's just much harder to attain a high protein diet when you're just having plant-based foods, because you have to eat a lot. And if your appetite isn't very good, it's very difficult to actually get that protein into you. We do support people on vegan and vegetarian diets if they really don't want to have meat, and that does happen. If we're talking about controlling neuroendocrine cancer, we don't have any data at all about what diet is best, and we don't have any data on preventing neuroendocrine cancer because we actually don't know most of the time what causes it.
Yes. And thanks for that, because that does come up a lot when people are trying to get enough protein in and losing a lot of weight or trying to gain weight. And so that's really helpful to just understand that there's a balance that needs to be had here. And along those lines, one question that comes up frequently in the support groups, I think this is a very common question: what kind of dietary supplements or nutrition do you recommend to help gain weight?
So I don't know whether that means pills or potions or anything like that, but we use oral nutrition support. We use these supplements, which are the shakes, MCT oil, and the powdered supplements, whey protein, all of that kind of thing. So they can help gain weight if you're not able to get more calories and protein in from just normal food. So if you're really struggling, especially with people with appetite problems, then you might not be able to eat large volumes, and then you'll be able to be prescribed a shake or an oil. So MCT oil is what we use alongside a low-fat diet when people have things like the bile acid malabsorption, because the fat is digested differently. We would only really use it for that group of people.
Okay. And when you talk about those oils and such, how does that relate to getting somatostatin analogs? Because I know people are worried about fats and oils if they're on somatostatin analogs.
Yeah, so the recommendation is not to decrease the amount of fat that you have. We need fat for all of the fat-soluble vitamins, so A, D, E, and K. And the recommendation is to take enough of those enzymes that I talked about, so the Creon and Nutrizyme, and the brands that you might have, which are different in the US. But it's certainly recommended that you don't cut down on fat, that you just up the enzymes instead.
Okay, that's helpful to know because I know, as you know, these questions are showing people are worried about cutting things out. And so you touched on, some of the oral supplements and the MCT oil. What about the nutrition shakes? What kind of shakes? Because I know that comes up quite often in the weekly support groups too. What kind of shakes do you recommend?
It depends. I don't personally recommend them as a first line. I really try to get calories and protein through food first, just because a lot of the shakes can cause diarrhea. And if someone's already got diarrhea, then I'm not going to make it any worse. Sometimes, especially with pancreatic neuroendocrine cancer and pancreatic surgery, we can use a modified supplement. I don't know whether you have Peptamen. We have one called Vital 1.5, so it has some MCT oil in it, and it's just more for digestive problems, people with sensitive stomachs. You probably have a few different brands, but we have Abbott Nutrition and Nestle and Nutricia as well.
I think those brands are found internationally, Nestle, Abbott Nutrition. Yep. So, related to this idea of protein that we're on, this person said that they cannot eat any animal protein or product because it's a huge trigger for syndrome. So what other suggestions do you have for protein?
There may be, so if they have carcinoid syndrome, aged meat, tinned fish, and kind of processed things like bacon and ham and salami and all those kind of things can be a trigger. But fresh chicken shouldn't be an issue, and fresh fish shouldn't be an issue. If it is an issue, maybe how it's cooked, spices, things like that, or fat, if they're using fat with that and not having enzymes when they maybe need them, that can be an issue. But if we're looking outside of animal products, we're looking at peas, beans, nuts, lentils, those kind of things, hummus as snacks, trying to have, plenty of those snacks throughout the day. And just really, as long as you've got the appetite, just keep munching all day.
Yeah, speaking of munching. Oh, before I get into the next question, just a reminder for the audience, if you have questions, go to slido.com, enter event code LACNETS, and you can submit your questions, and Tara is happy to answer them. So slido.com, enter event code LACNETS. Speaking of munching, if you can kind of clarify again, this whole issue of taking the enzymes gets to be really complicated and confusing, as you know, because I know you have this conversation quite a bit. Can you explain the rationale for taking half the enzymes halfway through the meal? And what if they're fast eater and eat all the meal in 20 minutes? Do they need the second
half? So the theory is that all of the enzymes need to get inside the meal as it transports through your digestive system. So we say half of them at the beginning, and then those enzymes get to the duodenum and the capsules open up, release the enzymes, they start mixing with the food, and then theoretically. I'm not sure whether it's been looked at and actually trialed, but half of the other half of the enzymes are meant to be in the meal. So they all just mix together and try to replicate what your own enzymes would do, because enzymes are pumped out through the duration of eating from a normal pancreas. So we're just trying to replicate what your own pancreas would do. And if you're a fast eater, well, you can just slow down. The other thing is that if you're having dessert, you also need to then have some more enzymes to digest that.
Okay. So it's better, you're saying it's better to break it up throughout the meal rather than take them all at the beginning of the meal. Okay.
Yeah. I think we used to say take them all at the beginning, but the more recent advice is to split them.
I see. And what if someone forgets to take their enzyme? What can they do?
Not much, I'm afraid. Once the food has gone down, it's very difficult for the enzymes to kind of catch up and start digesting what's already going through into the duodenum. So unfortunately, you may just have some time on the toilet. And just try and remember, especially when you're going out. I know we can't all go out as normal now and eat out, but I always give people a little pot, and it has space for about 20 enzymes in there. So just try and remember it.
So you're saying that if you forget and you've already started eating, or you're done eating, what should they do about taking it or not taking it?
You can try, but it's probably not going to work so well. There will be some food in your stomach, especially more fatty food will remain in your stomach for longer. So you can try, but don't expect it to work as well.
Okay. And you mentioned bringing it with you. So another question comes up, and I didn't put this in there, but another related question to the enzymes is, how should it be stored?
There's no special storage. Just make sure it doesn't need to go in the fridge, but they shouldn't go too hot, I don't think, because that would denature the enzymes. There should be information on your packet for the exact brand that you have.
Okay. So we don't want to be leaving it in the car if we're in California,
No.
like we are.
Yeah.
Okay. Well, speaking of kind of weight control, I know we talked about trying to gain weight. What about the other end? So someone particular has metastatic pheo to the bones, and are concerned about keeping their weight down. And they were looking at alternate day fasting, but really wondering about other weight management ideas that you might have.
Yeah, I mean, we don't often recommend weight loss unless someone's in the obese category, so BMI over 30. It's difficult to know with this case. Weight gain is not associated with a pheochromocytoma, so or mets to the bone. So I'm just wondering if this person had already been overweight, because that's not a symptom. So in terms of alternate day fasting, we don't have any kind of research within neuroendocrine cancer what you should use for weight management ideas. It would just be the standard weight loss, probably with a dietitian would be best. Alternate day fasting isn't what I would recommend personally, because you need to have lots of protein every day and get enough nutrition. And if you're only having half of that nutrition in a week, then it's probably not a good idea. But I would speak to your team about that.
Okay. This is a really interesting question, a little bit away from the weight and the protein. But have you had any patients who had hives or itchy skins, primarily at night? And could this be a niacin deficiency?
Yeah, some people do have itchy skin. It really needs to be discussed with the doctor. So niacin deficiency, which has visual symptoms, is called pellagra, and it can be itchy, but it's more of a visual diagnosis. So the doctor would need to make that visual diagnosis. You can have itchy skin just because it's dry, or because you've got kidney problems, or liver problems. So I would get that checked out. And there's lots of different reasons why you may have itchy skin.
Yeah, this comes up quite frequently. Well, there's people here who suffer from bowel obstruction, and sometimes they were diagnosed that way, or sometimes it happens, as you know. So this person asked, how can they balance their desire to eat vegetables and some whole grains and avoid the possibility of another bowel obstruction?
Yeah, so I'm guessing this person has already had at least one bowel obstruction. And what I would do is start to just blend the vegetables and whole grains. So they're really, there's no bits in there. And that would be the first thing that I would do with someone. So not reducing the amount of fibre, but just changing the consistency of the fibre. So the fibre is able to get past the obstruction. If the obstruction has got lots of desmoplasia, so lots of scar tissue around it, or the tumour is narrowing so much that the food can't get past there, then that's a different stage of diet, and we would go liquid only. So not even puree, it would be liquid as water, and other fluids would be watery kind of soups, thin soups. And if that doesn't work, then the final stage is food or nutrition into the blood system, called parenteral nutrition. But we try and keep people on a normal diet for as long as possible. I know it's not a nice idea to change, the look of what we eat, but if we can get the same vegetables in, and just start blending them and the whole grains, then at least we're keeping some kind of normality, and the taste isn't, changed. It's just the texture that's changed.
Mm-hmm. Mm-hmm. When you talk about blending these foods too, do you have any specific recommendations for how to go about doing this?
So a food processor, a blending smoothie maker, that kind of thing. So just making sure that they're really smooth. I guess the stage before that, which I would go through someone if they hadn't had a bowel obstruction, but they were told they were at risk, is really making sure that you don't get constipated. So having enough exercise, not eating too much fibre or too little fibre, and having lots of fluid, and really chewing things well. Your teeth do half the job. And so if you have teeth, then use them. But if we're at the point where we think there could be a bowel obstruction, yes, it would be first stage, you start blending things.
Mm-hmm. That's a good segue. You kind of talked about constipation. So what suggestions do you have if I fluctuate between diarrhea and constipation?
Yeah, so some people have constipation, and then they get something called overflow. So you have lots of diarrhea, and then you take something to kind of stop that, bung you up, then you have constipation. And then when the constipation is a pain, if you have laxatives, then you can get this burst of diarrhea for a day or so. If that's not the case, you can have diarrhea and constipation, which is alternating as part of irritable bowel syndrome, which you can get as well as a neuroendocrine cancer. So I think really you need to just see the dietitian, And also make sure that you're on the correct medications, that you're not, using laxatives and then getting diarrhea because you're on the laxatives. So you'd be surprised how many people actually have diarrhea because they're on laxatives and then they don't even know they're on laxatives. So it's a bit tricky when it's alternating.
Yeah. And so speaking of the bowel obstruction, what about people who have had colostomy reversal? How long does it take for your system to recover afterwards?
Yeah, so if we're talking about the intestines, it can take up to 2 years, but most people recover within a couple of months. So we just need to get the gut bacteria back to normal, get the function of the bowel back to normal, and have a reasonable amount of stools per day without any kind of watery diarrhea. So it should take a couple of months. Sometimes it's far quicker than that. So if you're in a good state of health when you go into an operation, you've had lots of protein, you sometimes there's kind of preparations for surgery now, special diets for surgery, making sure that people have lots of carbohydrate loading and things like that. So the better health you go into surgery, the faster your recovery.
That's a really good point. It's really important to prepare for surgery in more ways than just, all the medical and, those kind of things we often think about. So speaking of surgery, other types of surgery, do patients need to be on special diet after NET surgery? So I'm assuming, pancreatic surgery or intestinal surgery. If so, how long and how do I adjust what I eat afterwards?
Yeah, so it's really individual to that patient, and obviously there's so many different types of surgeries, and that relates to how much and where it's removed. So it's a bit difficult to answer that question. So how long should it take to recover? A couple of months normally for the average operation. And really, if it's something gastrointestinal, pancreatic, then you need to see a dietitian to help you adjust what you should eat. Sometimes there's no adjustment. If you have just a small intestinal resection, there's nothing really that you need to do. But things like Whipple's operations are major surgery, and you will need to change your diet, especially if you then develop diabetes, or you need enzymes. So if a significant amount of the pancreas has been taken away, straight after surgery, when you start eating, you'll need to start those pancreatic enzymes.
Yeah, that makes sense. So a follow-up question is something we were talking about earlier, just so I understand. If PRT seems to have eliminated all my flushing issues, could I begin adding food back in that were previously severe triggers?
Yeah, I mean, like somatostatin analogs, if the drug is controlling your symptoms, then you could just try one of those foods and see what happens. That's not an issue. It's a sensible suggestion. So just start off with one food and see how it goes.
Okay. And also, this person needs to eat very low fat, even with the replacement enzymes. And I eat lots of carbs and protein. But what suggestions do you have if and when I become diabetic and must avoid carbs?
So with diabetes, you don't have to avoid carbs. I think there's a lot of anti-carb, anti-sugar kind of messages these days, and it's just about having the right amount of carbohydrate for you. It doesn't ever mean avoiding sugar. That's never been, what we've said. So if you become diabetic or develop diabetes, it's normally healthy eating. So a reasonable, reasonable amount of treats, so small amount of treats compared to the rest of the diet, which should be high in fruit and vegetables. Every meal should always contain some carbohydrate in the starchy form, and it should be high fiber dietary fiber. So I think that should answer the question.
Okay. And something along the lines, again, back with enzymes, back with the somatostatin analogs, does high protein intake in place of fat promote gallstones? And you can answer this with or without somatostatin analogs.
I don't think so. So somatostatin analogs are a high risk factor for developing gallstones, but no, I don't think protein has been linked to development of gallstones.
Okay, thanks for clarifying. We were talking about the enzymes. Would keeping the pills in the pants pocket all day be okay for storage?
It just depends how hot it is, doesn't it? So if outside is very hot that day, then yeah, I'd try. And I don't know what you recommend over there, actually, because it's difficult to keep everything cool, isn't it, when it's too hot. But if your home is cooler, perhaps just in your home might be okay. If not, maybe use the fridge if that's your only other option.
So I'm assuming this might be a man asking this, but for women, could it be carried in their purse? Basically, does it need to be stored refrigerated if they're going out during the day? Or can it be in the purse?
I wouldn't take the whole pot out with you. I'd try and keep that cool and just take what you need. If it is a hot day, just take what you need. If you're just popping out for a meal, I would just take what you need, and then have them when you need them. But they shouldn't be getting too hot.
Okay. And this comes up a lot as well. Would over-the-counter pancreatic enzymes work for us, or is the prescription strength necessary?
Yeah, so this was covered in the presentation. So over-the-counter, probably not. And prescription ones are the ones that have been medically tested, so we know that they work. And as I said, they are from pig origin, and there are no current other brands, although there is one company trying to make a non-porcine variety. So we're just waiting that to come along, because obviously it can cause issues with religion, or people's beliefs when they have to take pig enzymes. They are allowed in Islam, and they are allowed when people are on a kosher diet as well. However, it would be nice to have an option. But certainly things like papaya enzymes, they're not medically tested. They're probably low dose and they may not work.
Mm-hmm. Okay. And this is an interesting question about vitamin supplements. Is it preferable to do a liquid or sublingual form of vitamin supplements, or the standard pills in regards to digestion and absorption?
It doesn't matter really. If someone had specific needs and was on a liquid diet, or they were having a tube feed, where we're just feeding via a tube, then maybe we would have to use liquid. But no, we're not too worried about the average patient, whether they have liquid or pills or capsules.
Okay, thanks for that. And along those lines with these supplements, can you clarify the difference between niacin and niacinamide, especially with the side effect of flushing?
Yeah, so niacin is what we have in food. So that's vitamin B3 found in food. Niacinamide, nicotinic acid, and nicotinamide are all supplemental forms of niacin. And it is recommended that nicotinamide, which we use for lowering blood lipids as well, is the supplement of choice for preventing and treating pellagra and niacin deficiency. And that supposedly is less likely to cause a flush. So often people ask about no flush supplements, and really that should be the nicotinamide, not the niacinamide or the nicotinic acid.
Okay. And what kind of dosing would you recommend, if any?
Yeah, so I recommend for prevention of deficiency about 100 milligrams a day, but the World Health Organization recommend 300 milligrams per day. There is a risk of toxicity if you go 1,000 milligrams a day and over. That can cause liver failure. So with all vitamins, you have to be really careful that you're not taking too high a dose.
Mm-hmm. Mm-hmm. And speaking of not too high of dose, is there a way that you can check levels in your blood?
So for this one, it's very difficult. So most centres do not test the N1NM, which is the urine test for niacin deficiency. Most centres don't have access to that test. I know there's no centre in the UK that does. That is the best test. Other centres use something called a niacin number, which is a blood test. And the published evidence from the US used the niacin number. And often when I see results from the US, those centres are using the niacin number. I don't think it's quite as good, but I'll still accept it. And we try and supplement based on that result.
Okay, thanks for that. I guess similarly, how do you get your vitamin levels checks? I mean, I think maybe meaning who checks them, how do you get them ordered, and who kind of monitors and follows up?
I guess it depends what access you have in the hospital. Sometimes vitamins and minerals are very difficult to get checked because if your lab doesn't process them, then you have to get them sent off. So it really depends what lab you have. Most of them are blood tests. There are a few urine tests like the N1MN, but most of them are blood tests. And really, in the ideal situation, you would then discuss the results with the dietitian, who is probably best placed in telling you whether you need to change a dose or add a dose or add anything into your vitamin and mineral regime if you're already on some.
Great. Related to that, I think what tests is recommended. I know you kind of touched on this again, but I think with the vitamin levels, what tests are recommended?
So it's really down to what kind of surgery you've had, what kind of cancer you've got, and whether you're, at risk because you're not eating so much. So that's a really difficult question. It's very unique. There's no one list.
We all wish that there were, though. But yes, we're all zebras. That's why I'm wearing my striped shirt for today, just as a reminder, because it's so different for each person. And speaking of differences, one person was advised that alcohol is not advised in any way with liver and small bowel neck tumors. Is a glass of wine gone forever for me?
No, probably not. I don't have an issue with occasional alcohol. If so, we're really looking at liver function tests, so the blood test, which come under the liver function panel. I always advise people to get printouts and know what their levels of everything are, know what what is high, what is low. And if you've got very, very high liver enzymes, then maybe not. But for most people, the occasional glass of wine will be absolutely fine.
Okay. Well, we have, about maybe 5 more minutes of questions with you. So if anyone has any additional questions they want to get answered, go to slido.com, enter event code LACNETS. We still have a couple more questions, so let me bring those up. But if anyone has any urgent questions, go ahead and get those in. So one person asks, do any kidney issues result from high protein diet, again, avoiding fat?
So if you have kidney problems, then you may need to adjust the protein in your diet. I don't know what the avoiding fat bit is, but a high protein diet is recommended for most people with any kind of cancer, not just neuroendocrine cancer. And perhaps this question is related to ketogenic diets. I'm not sure. I don't think so. But no, I don't think so, unless you've seen a renal dietitian and your phosphate is very high and you can't have a phosphate binder. Then no, I don't think that's an issue.
Thanks for clarifying. And Tara, what recommendations do you have for someone with very high insulin and C-peptides and cannot seem to lose weight, as I'm hungry all the time?
So if you have very high insulin, so I don't know whether this person has got an insulinoma, possibly. I'd have to know the diagnosis. If they've got an insulinoma, it's completely different, and we control blood sugar by trying to keep it stable so you don't go into a hypo all the time. Perhaps this person does, and weight loss can be difficult. So often these people have glucose drinks all the time just to keep their glucose high enough. But that isn't really recommended. It's about trying to have starchy carbohydrate, keeping the blood sugar level, and then if the tumour becomes active and you're testing your blood all the time goes too low, then you treat a hypo with the 2 stages. So something very sugary and then something very starchy afterwards to kind of prolong the glucose in your blood. But yeah, I'd have to know more if this isn't an insulinoma.
Okay, thank you. I think this question is related to how to get those vitamin levels checked. Would an internal medicine physician help or just a gastroenterologist?
For ordering the tests, I don't know what process you have over there. Most people can order tests. Any doctor can order tests. Some dietitians can order tests. So it really depends on your centre. You just need to ask someone.
Okay, thanks for speaking to that. Just being an advocate sometimes and figuring out who can do what, especially because it might vary both, by country, by state, and by centers. And, there's another question as a follow-up to your comment about itching. You mentioned liver and kidney issues in reference to itching. Can you comment a little further on
that? So especially urea, so high urea levels in the blood can cause a problem. So when you look at your blood results and the blood urea is high, then that's a common cause of itching. But as I said before, you'd need to see whether there are any visual problems with the skin as well, and get a proper doctor's diagnosis on what's going on alongside your bloods.
Okay, thank you for that. And this is the last question we have. What are your thoughts on omega fatty acid supplements?
Yeah, They are generally good. So several years ago, we really used to push omega-3 supplements. Very high doses were recommended in kind of late stage cancer, something called cancer cachexia, where the rate of muscle loss is very high. There's not so much kind of talk about omega-3 in terms of cancer these days. I think some of the studies found that they weren't useful, and I know dietitians are kind of pushing them less. I'm happy for people to have them if they want to have them, or they are at risk of heart attack or have had a heart attack. The first line, of course, would be to have oily fish. So over here, it's 2 oily fish a week if you've had a heart attack. So it really depends whether you've got cholesterol issues, really what your whole medical history involves. But I'm happy with them, and especially if they haven't got heavy metals in, which the pollutants from the sea, which can kind of be stored in our liver, then they're good to have, and they keep our blood nice and runny and thin and stop it from clotting.
Yeah, and just to follow up with that, are there any particular brands that you recommend?
Our brands over here are completely different, so no, there wouldn't be anything that I would know.
Yeah, and you mentioned oily fish. Could you just clarify which fishes are oily?
Yeah, so salmon, fresh tuna, herring, sardines, some kind of trouts are, pilchards, mackerel.
Now I'm getting a craving for fish tonight, I think. Well, with that, Tara, I just want to thank you for your time. You've been more than generous with all of your knowledge, all that you shared with us during the Q&A. And it's been such a pleasure connecting despite the distance, despite, all of that stuff that's going on. And we connect both in the net community, but also with the shared love of dogs and rescue dogs. So just thank you for so many ways we can connect. And our world is definitely much smaller now. And so thank you. Thank you so much for your time.
Brilliant. Thank you. Thanks so much.
And with that, I'll leave it back to you, Lindsay.
Thank you, Lisa. As a reminder, be sure you're following LACNETS on social media. We have a Facebook, Twitter, and Instagram. You can stay up to date on upcoming webinars and net news. Also, as a reminder, today's webinar is being recorded and can be viewed on our YouTube channel shortly after the live broadcast. Now off to you, Lisa.
Thank you, Lindsay. We understand that these can be challenging times, and we offer many programs and resources available to you, including our weekly NET support group, monthly NET caregiver support group, NET Vitals, which is a downloadable patient-physician communication tool to help you prepare for your medical appointments, and health coaching available to NET patients or caregivers. We encourage you to go to our website to find out more about our programs, visit resources, read blogs, take NET quizzes to check your understanding of all the information you're learning, and much, much more. We're excited to share with you all the speakers that we have lined up through the end of July. In March, NET expert Dr. Del Pasan will be talking about some novel agents, including copper-64 dotatate and targeted alpha therapy, or in other words, alpha PRRT. In April, Dr. Lisa Baudet from Memorial Sloan Kettering in New York City will be joining us to discuss PRRT 3 years after its introduction in the US, where we are and where we are going. Dr. Baudet has special expertise in the development of PRRT, including special investigational and molecular analysis to facilitate their diagnosis and therapy. She will also talk about the NET test, which is also of interest to many in our community. In May, Dr. Aman Chauhan will be joining us from the University of Kentucky to talk about clinical trials, the latest and the greatest in NETs. That meeting will take place on a Saturday for those of you who prefer weekend meetings, on Saturday, May 15th. And in July, our special guest speaker needs no introduction as he joins us every year. Dr. Eric Liu will be giving a talk called It's a marathon, not a sprint. Please also save the day for Saturday, June 19th. This will be our next virtual 2021 LA Net Patient Education Conference, and we also have an exciting lineup of speakers for that day. Thanks again to our speaker, Tara Whyand, Rich from TVP Live, and all of you for joining us today. See you on March 16th for our next webinar. Bye!
Bye!